Guys, so today we're going to be going over the elbow, and there's a lot that kind of goes into this. The anatomy isn't too crazy, but sometimes people get a little bit confused with the muscles and stuff. So for the anatomy side, the things to remember are the radius is always lateral when we think about anatomical position, and it has this really nice rounded head, and then the ulna is much bigger. And this is true when we're talking proximally. When we get to the wrist, they're going to reverse, and the radius is going to be really big distally, and the ulna is going to be really small. These two articulate with one another to make our radial ulnar joint, but then they both also articulate with the humerus. So the main elbow joint that most people think about is the ulnar humeral joint or humeral ulnar joint, depending upon who you talk to. And that's really where that hinge joint comes from. And then we also have the radiohumeral joint that goes on. And when we talk about when they're going to come in connection with one another, really, truly, the head comes in contact with the lateral condyle when we're in flexion, not in extension. You should be able to feel a big space here between the radial head and that lateral condyle. At least I can really feel it, and it's kind of like really round that goes around there. Because it really truly is a circle. It's a perfect circle, and it spins here on the ulna. So technically you have three joints, one here, and one here in the elbow itself. Okay. When we talk about the ligaments, the things to look for are, where is the radius? If it's not close to you and you can see this really triangle looking thing that looks a lot like the deltoid ligament in the ankle, you are looking at the ulnar collateral ligament. It's actually three bands in one that protect the medial side of your elbow. If the radius is on the opposite side, then you know medial side. And over here, what wraps around the radial head is called your annular ligament. This is a really important ligament for you guys to know because it's kind of weird. It attaches to the ulna, wraps around the head, doesn't actually attach to the head, it just wraps around it and then attaches to the ulna again. So it kind of works like a rubber band or a belt that keeps it in place. So that way the radial head can spin inside of it, which allows us to go into pronation and supination, but it doesn't actually truly attach to the radial head. And then opposite of this, we also have the radial collateral ligament that runs just from basically the just past the radial head or on the radial head up into our lateral epicondyle. So ulna, various aspects of the ulna up until the medial epicondyle, and then the RCL is on the opposite side. So this isn't the MCL, this is the UCL. And it's really important when you talk about the UCL that you mention where it is, because we have in the elbow, we have it in the wrist, we also have it in the thumb. So making sure that you're specifying what joint or what body part you're talking about is going to be very helpful. When you're trying to figure out where you are in space, remember I talk about a lot that you need to make sure that you can orient yourself when you're about to answer anatomy questions and or injury questions and stuff. The things to look for from an anterior side is, and again, this is separated obviously, right? But you can see these condyles, you can see this like kind of a dual hole kind of thing. And this is important. We're going to talk about this in a second, why these are here. So these fossa, the coronoid and radial fossa, what do you think goes in them? The coronoid and the radius. And then down here we have, this is the olecranon, which is that dude. Okay, the olecranon is your very pointy thing coming off your elbow, but this is the anterior aspect of it. So notice you can see cartilage here. Then this really nice articulating space, so it's very hollow or concave, and then it comes up to a point in the front, and this point is called your coronoid process. Then we also have the radial head over here, and you can see the tuberosity of the radius. And this is really important because this is where the biceps brachii inserts, which is why it's very helpful when we're in a supinated position to do elbow flexion. We're strongest that way because the biceps brachii is strongest in that position. Notice we can also see the interosseous membrane. We talked about that in the lower leg. And so that is going to hold your ulna and radius together, and we can get forearm splints and issues with that coming up. And so we also have that wraps directly around the head is that annular ligament, not around the neck, but actually around the head itself. From the posterior side, notice the cartilage doesn't look too terrible different, which is different than the femur, right? The femur was really, really different. But notice we go from two fossa to a singular fossa. And this fossa is where the olecranon process digs in. So think about, we have this really big bump, right? That's sticking out. And as I go into extension, it's curved like this, and it's going to dig into that hole. And we're going to have a really hard bony block as we go into extension. So if you see a singular hole versus two or fossa, then you know you're on the posterior side. Also notice this is rounded towards you, so convex. You can't see that tuberosity nearly as well, but the rest of it kind of looks sort of similar. So really paying attention to, if I can see this or the two notches, and if I can see the coronoid and the tuberosity, these are some of the biggest things to pay attention to when you're trying to orient yourself. Also remember, again, the radius is always lateral. We're in an anatomical position, it's always lateral. When we talk about the ligaments, don't worry so much about the capsules and stuff like that, but here's a really nice depiction of the annular ligament and how it wraps around the radial head. And then you can see the ulnar collateral ligament and the radial collateral ligament over here. Again, the ulnar collateral ligament, the annular ligament, and then the tendon of the biceps. Remember how I said this comes down onto the radial tuberosity, which is going to be an important attachment site. Back here, we have the triceps tendon. So that comes in and inserts on that very proximal aspect of the olecranon. So the olecranon is our attachment site for our triceps. And then here you can see the lateral side. This is our radial collateral ligament that runs on the lateral aspect of the radius and then inserts on that lateral distal aspect of our humeral epicondyle, lateral humeral epicondyle. Okay. From muscles, hopefully you guys can tell the difference between biceps and triceps, but your biceps, we're going to have a long head and a short head. So notice the short head is medial and the long head is lateral. And we at the shoulder talked about how the long head goes all the way up and inserts on the superior aspect of the glenoid tuberosity. And then they come together as a conjoined tendon and insert on that radial tuberosity. Posterior to that, we have the brachialis. Superior, we have the coracobrachialis. And then we'll talk about a couple of the other muscles that are under here. We did talk about the brachioradialis previously, which we can see here. So this brachioradialis, again, if you look at the hand and look at the position of the shoulder and you can see the triceps, that means that you're looking at the posterior aspect, right? So starting up here with the triceps, tri means three. So we have three heads to it. And if you look at this, we have the long head and the lateral head. Long head is medial, lateral head is going to be lateral. Wow, that shouldn't have taken me so long to say that. And then we have the short head that lies deep to these. So three total heads. Notice where they're all inserting. The lateral head doesn't actually cross the shoulder joint, but the long head does cross the shoulder joint and it inserts onto the scapula. The short head is shorter than the lateral head. So really only one of the three heads actually helps with shoulder extension. The other two heads only help with elbow extension. So we're much stronger. These are much stronger in elbow extension than shoulder extension. Now, does that mean we don't have other muscles that help do that? No way, man. And we talked about that with the shoulder. We have several other muscles that help with shoulder extension. And then this is our aponeurosis, or the conjoined tendon, where they all come together. And again, they insert on that proximal olecranon. Our brachioradialis comes from here. And this was talked about a little bit before accidentally in the shoulder. So your brachioradialis is a lateral muscle. It comes off of our, our distal distal humerus, kind of near the epicondyle, and it runs across the elbow. And a lot of people think that it goes into the hand, but it really ends down at your wrist. And I call it your beer drinking muscle. So if you're holding on to something like my apple and you go up like this, it's going to flex up. So as you come up, you're going to see that muscle that sticks up. That is your brachioradialis, which is why when you're in a neutral position, that muscle is what's really keying in the most. Like you're going to see it really kick out the most. The other thing to think about is, so we have extension and flexion of the wrist, and we're going to talk about this because this is the elbow and forearm. So understanding these things are going to matter. So wrist extension is coming up, wrist flexion is coming down. If you come up, you should see and feel all of these lateral muscles get tight. Okay. Can you see that? Maybe, hopefully, maybe not, but they are. I can see it and feel it. So these lateral muscles are getting tight. And then as you supinate, so supinate is bringing your hands up like you can carry a bowl of soup. Pronate is putting your palms down like you're going to pour it out. So supinate, carry a soup bowl. Pronate, pour it out, or palms down, whatever is going to help you think about that the best. So this whole group of muscles, so it's on the lateral posterior aspect of your arm. Actually, some of it's on the anterior part. It just depends upon which one you're talking about. These are all your wrist extensors and supinators. So when you supinate, they're going to contract. And when you extend your wrist, they're going to contract. Conversely, on the medial side, medial anterior primarily, what you're going to see are your wrist flexors. So if you come down, you should see these muscles get solid. Okay. So these are our wrist flexors and pronators. So as we come down into flexion, especially if we pull all of our fingers in and then we pronate, that's how these guys are going to get really, really solid. Okay. So right here, we're looking at the extensor supinator group. Then when we look at the anterior side over here, we're going to have the flexor pronator group come from that anterior medial side. Remember, flexion is curling everything in, extension is pulling everything out. A couple key things to pay attention to when we're talking about specific muscles. Ulnaris, when we look at this, again, your ulna is going to be on the medial side. Your radius is going to be on the lateral side or thumb side. So if you see ulnaris, it means medial. Okay. If you see radialis, it's going to mean lateral. If you see, what other words? Obviously, longus and brevis are going to tell you if it's long or short. If you see digitorum, same as in the foot, it means it's moving your digits. So it might be coming down to any variation of these phalanges or phalanxes. Palmaris is your palm. That shouldn't be too difficult. When we talk about a pollicus, they're meaning thumb. Like we had the hallicus in the foot. Pollicus means thumb. And then they don't have it on here, but digiti minimi means pinky, and indices means our index finger. So we don't have any special ones for these two fingers, but we have them for these three fingers. And for extension, these three fingers have their own extensor tendons. These guys are all pulled together. So if you try to extend your ring finger, notice the other fingers start coming up with it. And it's because they're all getting pulled by the extensor digitorum. And when you flex, I can pull this one down, but notice it pulls this guy down. I can pull this one down, but it kind of pulls the other ones down. So we're doing the same thing on the flexor side. We do have individual flexors for our pollicus, for indices. But when we think about the others, these four are still pulled together by the digitorums as well. Okay. Nerve and blood supply as we come through here. So we've talked before about the subclavian artery that becomes the axillary artery that then becomes the brachial artery. And then the brachial artery splits right at the elbow and it becomes the radial and ulnar. Pretty simple, I think. Nerves are a little bit different. And for this class, you kind of need to know what they are. We're not going to get too crazy about them. A couple of them are going to be really important for certain injuries, though. So you're going to have to know them based upon injuries. In other classes, you're going to have to know more about like testing and stuff like that, like up in upper eval and stuff. So we have three major nerves that come out of our brachial plexus and go down our nerve or go down our arm to help innervate. So the median nerve runs basically right down the center of the anterior aspect of your arm, like the whole thing, like it crosses through the very center of your wrist. So it basically runs right there, pretty protected. It innervates a lot of things. Our ulnar nerve kind of comes out of our armpit and runs a little bit posterior, and then right in between our epicondyle and the olecranon, like right through here, you guys can probably feel a little divot. If you extend your elbow a little bit more, it's a really big divot, and then as you flex it, it becomes less so. So big divot in here, and then it pushes you all the way out. You see that? Big divot pushes you out. This is right where your ulnar nerve sits. When you hit your funny bone, you always do it in a flexed elbow position, never extended. Why? Because when it's extended, the ulnar nerve is tucked way up in that space. When you flex it, it's pushed out by all that soft tissue. So it's really superficial. So when you slam your elbow on something, you're directly hitting your ulnar nerve. Or if you sit with your elbows for a long time on like some kind of armrest or something, you're usually applying direct pressure to your ulnar nerve, and it could cause problems all the way down that medial aspect of your arm and down into your hand, and often can cause numbness, weakness, tingling down into your fourth and fifth digits, which can be a problem. Trust me, I've had it. It's not so fun. And we'll talk about the ulnar nerve when we get to the wrist and hand too. And by the way, this is called your cubital tunnel. Okay. This is called your cubital space, or antecubital space, meaning opposite cubital. Okay. And then your radial nerve runs down the posterior aspect of your arm and innervates the posterior stuff. So extensors. All right. And this just kind of shows you a little bit how they come down. Don't worry so much about the musculocutaneous, but again, the medial, radial, and ulnar nerves, I think, are important for you to understand. We've talked about the arteries already. This is just another depiction of them. And for the veins, just kind of know that they're similar, axillary, brachial. We won't worry about the rest of them. For functional anatomy, we can do flexion, extension. So it is a true hinge joint, the humeral ulnar joint. And then we can do pronation, supination. So pronation, again, pour the soup out. Supination is carry the soup. I want you to always do this with your elbows flexed, much like we did at the hip when we talked about internal, external rotation. Same here. Pronation, supination, and also same as the shoulder, internal, external rotation. Always do it with your elbow flexed, all of these rotation things, because otherwise it's really difficult to tell where the movement is coming from. So always elbow flex. So flexion gets to about 145 degrees, extension is 0. Supination and pronation, neutral, thumb up. You should be able to get to at least 90 in pronation and at least 90 in supination. Some people can get way further in both directions, but at least from straight up, 90 this way and 90 this way. We do have something called a carrying angle. If you look at people's arms, they're not just like straight down. They kind of have this valgus stress to them a little bit. Females, we typically look at 10 to 15 degrees, and males closer to 5, kind of similar to like our knees and our hips, right? Women have greater Q angles and stuff. They should not be straight. And we'll talk later about how straight indicates that there was some kind of, well, there was usually a very specific injury. But know this, the females 10 to 15, males 5 for their carrying angle as we're moving around. And then when we talk about assessments, think about what you're asking. And these are very similar to what we've done in the past for PQRST, swelling. What did you do before? What have you done for those injuries before? When and where does it hurt? All that kind of stuff. Okay. Observations, nothing new, but we do need to add that carrying angle in there, and that cubital valgus versus varus. I've never seen varus. People's elbows don't lean like they're bow-legged. They come in like they're knock-kneed kind of. Flexion extension. So at the knee, we call it genu recurvatum. If they hyperextended, I totally hyperextend just like I did at the knee. So I think this looks pretty straight to you, maybe. This is straight to me. So I go into at least 15 to 20 degrees at hyperextension. You need to measure both sides to see if they're the same, because if not, maybe they broke off their olecranon, which is why they can go so far or something like that. So that's definitely something to consider. And then you also want to look at the elbow when it is at 45 degrees of flexion. So when it is bent versus straight, it's going to make a difference. When it is straight, it should basically be the two epicondyles and the olecranon should line up, and it should be a straight line. Notice that's what it looks like here. This makes it look like she's flexed to 90. I promise you shouldn't be flexed to 90. You should be flexed to 45. But notice when you're flexed, the epicondyles are superior to that olecranon, and it should be a really nice triangle as we look at this. So an isosceles triangle with between the epicondyles and the olecranon. Okay. All right. Palpations. If it's soft like a muscle, it should be soft. If it's a bone, it should be hard and bony. Nothing crazy here, I hope. Anyway, so special tests. Circulatory and neurologic function. We've talked before in previous chapters about PMS and how we do cap refill and all that kind of stuff. In chapter 13, we talked about how do you assess a pulse. So cap refill, again, squeeze the end, and it should be red or return of color in less than 3 seconds. When we're going to assess a pulse, you can try to check it at the elbow, but it's much easier to check the radial pulse or the ulnar pulse. Remember, radial is closer to the thumb, ulnar's on the opposite side. And don't push crazy hard. If you push crazy hard, you're going to crush it. So it should be a nice pulse, and never ever take a pulse with your thumb. Tinel's sign, Tinel's, and this is true throughout the entire body, is a tapping. And again, we talked about this in the lower extremity, where you would tap on some of those superficial nerves, particularly down and around the ankle and foot. For this, remember, we talked about the ulnar nerve. So you can tap in that cubital tunnel to see if you can get like a reproduction of their symptoms. Again, you would have to have them in a flexed position so that ulnar nerve is pushed out. You can do it with your finger, but typically you'll use like a one of the little reflex hammers or something like that. It's also called the ulnar groove. And if they have pain, weird sensation stuff, whatever, when you hit it. Now they should have pain. Let me go back. If they have a reproduction of the symptoms that they're complaining of, that is a positive sign. But if they just have like random shooting down and things that are associated with hitting your ulnar nerve, that's normal. For capsular injury, this is very similar to the knee. Remember, we did varus valgus stress test as we assessed the knee. So if we were looking at capsule stuff, we did it with them straight, and ligamentous stuff with them bent. And so as we're going to be looking at these things, it's going to be the same kind of thing. Capsular injuries tested at after hyperextension of the elbow. So when we're doing this guy, the elbow's flexed to 45, the wrist is fully flexed and extended. When we're talking about this, sorry, let me back up. When we're talking about this, we're looking at capsular injuries like anterior, posterior. So what you're going to do is flex the elbow to 45 and then fully extend and fully flex. And so you're looking to see if they're having pain and things that are going to be a reproduction of their symptoms, which is not awesome and it hurts. This guy is what I was talking about previously. Sorry, I didn't look at the PowerPoint slide. Very good. So we have varus and valgus stress tests to assess our UCL, ulnar collateral ligament, and our RCL, radial collateral ligament. Again, we do it with them straight. And then we're going to flex the elbow to 20 to 30 degrees and do the valgus stress test, so coming in, or the varus stress test going out. We do them the exact same as we did the knee. So again, straight is capsular, flexed a little bit, 20, 30 degrees is going to assess the two ligaments, the ulnar and collateral ligament. When we're going to look at epicondylitis, so meaning like a tennis elbow, so an itis is an inflammation, right? When we do that kind of stuff, again, we're going to flex it back to 45 degrees, like what we did for the capsular test with the potential elbow dislocation. But instead of just moving them into flexion extension, we're actually going to resist them into flexion and extension. And pain at the medial or lateral epicondyle is going to be a positive test. So flex, come up, resist me, and then push them back down. And same thing, flex and push them back down kind of thing is going to be a problem. Another one is a pinch grip test. So you would have them squeeze and pull apart, pull apart, pull apart, pull apart. You should be able to pull them apart, but it should be kind of hard. And you do it on the opposite side. Like I can really resist myself. I have to like pull. Now, as I move further through my hand, I don't have to pull as hard because like my pinky is not nearly as strong as my index finger. But you would do this with their good side first and then do it with their injured or affected side. They should be able to touch all of them together, and they should at least be able to resist some as you try to pull through there. But if they don't, then you're going to be looking at potential nerve issues that are going on, or maybe they did have some kind of muscular damage that could be problematic. Functional evaluations are going to involve throwing, jumping, all of that kind of stuff, and trying to figure out what we can do to make them reproduce their symptoms and see if things are going on. And for upper extremity, I think I said throwing and jump or running and jumping, throwing, dribbling, like picking stuff up and moving things. All of that are things that we would really want to pay attention to and start working on. Pain and weakness, we're going to look at them through all of our ranges of motion. So active, passive, resisted range of motion. Remember, resisted range of motion is break tests. And supination, pronation, don't forget those guys. So having them turn in for pronation and turn out for supination. And these are going to be really important to see if they're limited, but also their strength, because so many muscles are involved in that. But also so much of what we do is going to be affected if we can't do that. Think about how you drive. So like if you're going to turn a corner, do you turn it like this? Do you turn it like this? Do you use both hands? Like, what do you do? But all of that is pronation, supination. Opening a door, any kind of door handle, you're going to usually have to turn somehow. There's lots of things, guys, that we do that involve pronation, supination, including opening bottles and stuff like that, jars and stuff. It becomes very difficult. So understanding that, I think, is really important, and figuring out how we can attend to some of that stuff is going to be key. The next one that we're going to do is going to be our injuries. Okay, see you soon.